Broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, everyone, and welcome to HTN's Digital Primary Care event. We've had some great sessions today from Dr Manal Bakai, Dr Osman Bhatti, generated health and babble voice on various aspects and topics of digital primary care, including access to patient records, digital-first primary care, remote monitoring to behavioural health, empowered self-managing patients are saving overloaded clinical teams, and advanced telephony in the age of primary care networks. All of these sessions have been recorded and they will be available on the HTN website from next week. This next session is being presented by the team at Dictate.IT on patient consent, how dictation can help. We're being joined by Professor Vivienne Harpwood and Dr Senad. So thank you guys, that was a really, so just hand over to you guys.
Thank you, Emma. Good afternoon and a very warm welcome to Dictate.IT and our webinar today. My name is Jan Donnelly and I head up the primary care side of our business. And with me today, as Emma has just said, we have Dr Senad, who is a GP and a specialist in ENT surgery. He is also a medical advisor, which is why we've asked him to join us today. And thankfully he has, so thank you, Senad. Also, we have Professor Vivienne Harpwood, who is a professor of law at Cardiff University. And again, thank you, Vivienne, for joining us today. So our webinar today hopes to cover medical dictation as being far more than just the correspondence or the secretarial workflow, which you would probably normally associate dictation with. Now, obviously, the original workflow using a dictaphone still exists, and many people do still use this. But we now have moved on, and we have a mobile phone app using artificial intelligence. We call this one Swift. And this dictates directly, so with the clinician would dictate into the mobile phone using this app, into the patient record, and it works with EMIS or TPP and others from anywhere at any time. And within seconds, this would go back to a web portal for the secretary to pick up. And at this point, it will be transcribed and formatted in the web portal. So all they have to do then is to manage the correspondence. So saving a lot of time for the secretarial team that they can then use on other things that they now have to do, which are equally important. Another service that exists, which not everyone is aware of, or if they are, maybe don't realize how they could use it or how it could help them, is our live system, which is a clinician administration tool. This is provided in the form of a desktop app, again using artificial intelligence. And this is for the clinicians to manage everything they would normally manage using a cursor, so typing. Anywhere they can put the cursor, they can dictate. So that would be obviously into the EMIS TPP records, anywhere within that system. Also to Word, to email, other apps, for example, insurance claims. And there's even a canned text feature, which enables a set of dictation to be used repeatedly. So if, for example, it could be as simple as your signature, which you use every day. So you could record this as text 1 and then just say insert text 1 and it would do it for you wherever you put the cursor. So again, it's all designed to save you time, but also allows you to capture as much information as you need in every instance of your working day. So now we're aware there are systems available to help save time and manage clinicians' workloads. What does that mean and how would we use it? Over to Senad.
Yes, good afternoon, everyone, and thank you very, very much, Jen, for that lovely introduction and for inviting me also to speak about this. So, as you have said before, I'm a GP partner and I'm also a specialist in the ENT surgery, have worked in many different hospitals in ENT departments in UK and have been also doing some medical advising on a variety of different approaches, how to improve the actual delivery of care and how to improve the healthcare in general, right? So my thoughts, which I have basically summarized here, let me put it that way, in a way, how the documentation in primary care looks like at present in UK and about the role of the digital dictation in a life of a busy practitioner, if it's a GP or whoever is actually having a patient contact in normal everyday life. Also about the documentation and consent, and what I think actually consent now means in terms of the medical documentation and work as a medical professional in general. Next slide, please. So in my view, the work as a doctor, I've been working as a medical doctor for many years already, and I think that the work of doctors or medical professionals in general has stayed pretty much the same. You know, we see patients and we need to try to document that what has happened. And in the beginning of it all was simply writing things down, right, in a relatively brief format. Population density and size was relatively small. And then we got a typewriter, then after that, finally, we got a computer and electronic care records and all of that. And now we have this possibility to basically do the documentation with self-learning programs, software, which is adapting to the user to basically document that in as good quality as it was basically pronounced and said, but also within a shorter amount of time than normally we would be able to do that, because it's like you can hear me speaking now, and if I would need to write all of this down, I think I would probably struggle, although I do write every day. So there's a lot of time gained. So for me, this ability to dictate any encounter I have with a patient, be it a physical examination, or if it is an email correspondence or a telephone call, a possibility to use a dictation tool, which is basically automatically transcribing that where I need it to be transcribed, is invaluable for me in my everyday work. And it's a really, really busy day, you know, every day when I work, and it's really resolving many problems. Now, next slide, please. So in terms of consent, that usually, having been on the surgical side, also in hospitals, people connect the word consent with surgical consent or consent to do something where something explicitly needs to be discussed and things like that. In a world of primary care, or as a GP, every time I speak to someone or someone speaks to me or exchanges information, a decision has been made, and patient decides based on that contact, whichever format the contact was in, what they are going to do next, or I help them to decide what they are going to do next, right? So that is basically the consent. People consent in every single encounter to do something or not to do something. And that's really a key point for the rest of the presentation as well. Now, what would be a good practice in capturing information? So there will be a variety of different definitions. However, the people who do it every day, like GPs, nurses, every medical staff member, they need to document that. They type it usually up, and the extent how they document these things often depends on the available time, on the role, of course, what the professional is actually doing and what his role is in the system, but also on the perceived need to document, what they think needs to be documented, right? Next slide, please. So what is the purpose of it today, in my view? Describing, right? I have tried to make this slide relatively simple so that it really reflects a variety of different purposes as I see them today, right? And I have broken that down into 5. So the first one is describing. What is it actually what has happened, right? I have spoken to someone over the phone or have examined him, so I have to describe it as good as possible the whole context of consultation and everything what was there in as much detail which is relevant as possible. So it needs to be the quantity and the quality of the content needs to be suitable, right? Now exchanging of medical notes. In primary care, we are really embedded now in electronic networks where people can see these files which we create. If it's something that I have dictated or written into a patient file, it is being exchanged among a variety of different professionals. Hence, the better I do that, the more likely it is that the care which is being shared is going to be as safe and as effective as possible. Handover is quite an important one. So we all have annual leaves, there are sickness leaves, all sorts of different reasons why people have to hand over their patients to someone. And when people leave, often it is like that, that there are sometimes subtleties in information which have been particularly in the primary care, where relationship building is something what is often happening over years and years and years, and you get to know your patients really, really well. So this handover is better when you can basically capture more and exchange more information with whoever is going to take over your patients from you, right? Future proofing. What that means for me is that access to patient records is becoming and is a norm where people can actually see what has been discussed. And it's not just for medical legal purposes and so on, but often as a reminder as well. And I think as time progresses, that this is going to be something that's going to be always more prevalent. People will be able to almost automatically probably get a summary of what was discussed. And in order to get that, I think that these modern tools which are transforming our verbal speech into written content are invaluable tool in way forward. Understanding the previous course, every time I have to personally make a decision, the only way how I can do that is to understand what happened before. And the more has been written and documented, the easier it gets and the safer it gets. So that is basically the 5 purposes of the documentation as I see them at present. Next slide, please. So what is the actual work, right? So how do you do it? Why do you do it? Different people have different approaches how they would do it. There is an approach type now. So people speak, and while they are speaking to you, you do your typing. It is sometimes necessary, but usually people see that as you being distracted by doing something while they're speaking to you. It's not really a thing that people want to see, because it is important, but it's breaking down that relationship a little bit on the point of contact, where particularly when sensitive things are being discussed with the practitioner. Type later, people will basically do that. They will reverse it and they will say, fine, let's speak now and just go through everything, discuss it, and then I will type it up. And of course, there is a dictation as a possibility. Now, the documentation in the context of a regular working day in a primary care. So there are numerous encounters, and now through development in modern times, these encounters are largely, for one part of the day, they are digital, which means it's an exchange of written information, and also from telephone calls and face-to-face appointments. Now, each one of these really needs to be documented as accurately and comprehensively as possible within that what was discussed. So not everything, of course, needs to be a novel. Some things are. And things change from one patient to another. There may be a documentation need from a couple of sentences for repeat prescription or something, up to a new episode, which is really important to be described in detail. So this is the documentation in the context of a regular working day. Next slide, please. So what are the constraints? What would it be that where I would say, I understand that this is making it difficult or tricky for things to be documented as they should, right? So of course, it's the lacking of time. and lacking of tools. So it's not everyone has an access to something like a digital dictation tool. Now, lack of awareness of documentation, which is needed, and lack of awareness of consequences of the poor and insufficient documentation, right? So the awareness of documentation needed, it requires some medical legal knowledge as well as medical knowledge in general, and years of experience. Now, the use of modern technology in the primary care, how to make our work smarter. The work is as it is. It's not getting less, I'm afraid. It's getting more. So what are the options? What is it that we can do? And I think that when a digital dictation is available, the big thing really for me there, or to basically use this and not something else, is irrespective of my tiredness levels, right? Some of you may be distinguished that English language is not my primary language, and you may sound different, but the good digital dictation tools, they really hear every word and they write it up exactly like you would do it if you would be typing, just quicker, right? They don't get tired as the day progresses, you know. So irrespective of how tired you are, or which language you speak, this is going to have the same quality of the output, which is very good. Now, in places where the medical staffing is coming from a variety of different linguistic backgrounds, this is quite an important thing, because it is making sure that, you know, it's easier to document things because they are simply transcribed in English, irrespective of what the native tongue or accent may have been. Next slide, please. So the advantages, I see many, and the quality and the quantity of things which can be produced, and of course saving of time. So although I have been working as a doctor for many years and have been typing for many years, it's very difficult, almost impossible for me to produce the amount of content I can dictate in the same time in which I would type. So I would dictate and I would gain loads of time with that. So I'm saving time which I can use for whatever I need it for. It doesn't really matter what it is, even if it's a break or some other task, but I'm getting something when I'm lacking. I'm using it for communications, so external communications, internal communications with messaging system within medical documentation systems. The possibility to moderate the workflow is quite an important one, because I may be interrupted in the middle of dictation with something, with an important message which needs really urgent reply. The only thing I would do is I would move my cursor from the medical documentation system into the message, dictate what I want to say, send it back, and then go back into the documentation of the consultation, or whatever it was, with moving the cursor back. Now, medical legal aspects, what hasn't been written doesn't legally exist. This is a simple fact which I have learned through years of work as a doctor, right? Now, the documentation as such, even if I go, for example, to do a home visit somewhere, or whatever it is, or if paramedics I use it, people who work in the community, they can use this to dictate directly into patients' notes, which is a huge advantage and time saving, because they are as busy as we are all. Is this a perfect tool? No, it's not. While I was starting to use this, I have seen, okay, this word or the other word hasn't been transcribed properly, but it's fascinating to see how the software is learning, how with time there are less and less and less mistakes, and I need to polish things up. So even though I have to return sometimes to correct something, it's still a huge time saving and efficiency improvement. Next slide, please. So what do I use it for? So I have already emphasized roughly what it is. All medical notes, all types of communications I personally do. Emails, messages, internally, externally, generating of different type of medical written materials. Now, the key word is medical, because the software has very good medical vocabulary, and it's really working very well with all sorts of different conditions, which we describe in primary care, which is essentially whole medicine. So who can use it? Everyone, right? GPs, nurses, district nurses, paramedics, pharmacists, whoever needs to document can use it because it's really simple. Next slide, please. So what is the common ways? What is what people would usually do when this is really not available? And usually, in many cases, unfortunately, it isn't. So we're trying basically to type up all relevant information in as much time as it is needed for things which need to be there. So that will typically mean that it eats into your day. Your day is longer because you really needed to put these things down and to leave them there, and you will be doing it with typing. Now, the extensive documentation, the more complex the encounter, if I can put it like that, the more need for adequate documentation is going to be there, and the time is really, I think, incredibly scarce resource which we have now, particularly post-pandemic. So who can see my notes? The question is, who is it? Embedded in electronic networks, it's all GPs in primary care networks. When I write referrals, my documentations are in consultations have been attached to these referrals. People in A&E, all sorts of medical clinicians there, patients themselves as well, all primary care professionals, and in case of some indemnity claims, legal professionals. Next slide, please. So in general, what I want to say one more time, so the digital dictation in terms of documentation for me is a significant evolution of documentation possibility, as something what improves the quality as well as the quantity of the documentation which I can do, while I'm basically getting the resource back which I need to be able to tackle all these other tasks which I do have every day as well, and that is time. Thank you very much.
Thank you, Senad. Really much appreciated. There's an overview there which just says really what Senad has already said. So I don't need to really read that to you. But I would say that at this point now, it's great to move on to how Professor Harpwood, Vivienne, would see how we do this and what we should capture. So over to you, Vivienne.
Thank you. Good afternoon, everyone, and I'm delighted to be able to speak to you this afternoon. I've been talking to clinicians for very many years about consent to treatment, and I've watched the law evolving just as the technology has evolved, which is being used by clinicians. So I'm going to talk today, next slide please, about consent to treatment in sort of general terms, but I'm going to go into some detail about why good consent is important, and good consent is informed consent. So I'll start by talking about how the law on consent has changed. So over to you for the next slide. Thank you. The law on consent to treatment has changed and developed since 2015, and really this case which is now known as the Montgomery case, because that was the name of the claimant, Nadine Montgomery. This was decided by the Supreme Court, that is the highest court in the UK, in 2015. And the way our law works is that the higher the court, the more important the decision. Since that case was decided, other courts have developed it to some extent, but it's very clear that consent must now be a shared process based on honest conversations between clinician and patient. And the emphasis is on the need to support the autonomy of the patient. And that brings our law in line with the law in many other countries, as it was before 2015. So the law now requires doctors to provide each patient with information. Next slide, please. And I'm going to talk this afternoon about why clinicians do need to have knowledge and understanding of the current law. I mean, if we just look at one aspect, and this is not the most important aspect really, the most important aspect is that they can gain the trust of their patients and act in their best interests. But if we look at compensation payments in England alone, in that 1 year during the pandemic, a huge amount was paid out by the NHS in compensation and costs in relation to claims involving failure to warn, that is consent to treatment cases. It's unbelievable that more than 415 million was spent on that. So next slide, please. So what is this personalized approach? The patient-focused legal principles, in other words. The doctor is now, and not only a doctor, anybody, any clinician taking consent from the patient, is now in a position of having to try to understand what is important to the individual patient. What to that patient are the material risks? Checklists can be useful, and I'll come back to those at the end. But basically, it's very, very difficult because from a mere lawyer's perspective, it's very difficult to understand exactly how doctors gain the information they need to give their patients that crucial information. Next slide, please. So what obtaining properly informed consent involves is, first of all, time. And Senad has already mentioned that. Time is very short in a busy clinic. It's very difficult to get through a long list of patients if you're a GP, for example. Now also other patients who are waiting for telephone consultations as well. So time is of the essence, and time is very important. And while I'm on the subject of time, I should mention perhaps that if there is a very urgent situation, a real emergency, what I'm going to talk about, of course, will not apply. I'm talking to the normal sort of situations, not those situations where someone might die unless something is done immediately to help them. So time is very important, but so is sensitivity, because any discussion with the patient must be tailored to the needs of the individual patient. And it does take time to get to know sensitively, get to know that patient well enough to understand what their values are, what their views are, what their fears are, and answer any questions clearly and in a sensitive way that is meaningful to the patient. Next slide, please. I'll come back to some of that. The making and retaining of detailed records and consultations is vital, because it's important to be able to demonstrate as a clinician that the patient has been given that information and that they have understood it, that they've been given enough time to ask questions, and that the clinician has allowed the patient, if you like, time to reflect. And that might involve taking away information in the form of notes to the family. And those notes will contain clarity of detail. People are more and more now using that opportunity. And I know from long ago, some clinicians, some consultants in oncology, for example, were allowing patients to take tape recordings many years ago of their conversations during a consultation so that they could go away and really think about what they wanted to do. So great clarity is important. And very, very important is the evidential aspect of this, because failure to observe legal principles could result in a claim for negligence in certain circumstances, and also, heaven forbid, a complaint to the GMC, or having to appear before an inquest and be grilled about what happened in the event of a death. And all of these things can be extremely stressful. for the doctors involved. I mean, I have practiced as a barrister, and I've observed how difficult it can be for the most confident of people. So it's therefore vital for doctors to keep accurate and detailed notes in some form of all consultations, because consent is an issue, as Senad has said, in virtually every situation, every consultation. For legal purposes, the best evidence is contemporaneous written evidence, and I call that the elephant in the room. If ever you've been in a criminal court and seen a police officer having to give evidence, you will see that he's asked by counsel, when did you make these notes, officer? And he'll have his notebook in front of him and he'll say, oh, at the time or immediately afterwards. So that is the best evidence, not years later, as happened in one very interesting case called Belitha, which is also extremely important, in which the nursing notes were excellent because nurses had a lot more time, and the notes of the poor registrar in that case were virtually non-existent. And when, of course, asked what she could remember about that evening, she was in a bad position. She could not say clearly what she remembered because it was a very long time before the case actually got to court, as it always is. So very important then for legal purposes. And of course, everybody understands how difficult it is for doctors, including the nurses, I hope. So I want to talk then about, next slide, please. The details of this checklist in a minute. But if I'm going to give you an example of a patient who's a professional pianist requiring hand surgery, and even before that patient gets to see the consultant, really the doctor would need to ask the right questions in the right way to find out, first of all, that the person is a pianist at all, and then what the proposed options for treatment would be for that particular individual and how they might affect that person in their career. So a lot of difficult information to extract, if you like, from the patient. The ultimate decision is, of course, with the patient, and that decision should be made freely and without any pressure, bearing in mind that consent is an ongoing process and the patient can change their mind at any time. But it's been clearly stated in one case that if the patient asks questions, the doctor has a duty to answer them honestly. And that is vital. Honesty is very important indeed. So I'm going to talk about the advantages for patients in being able to read their notes and being able to have the confidence that they've said everything they wanted to say and understood everything. So it's very important for the doctor or other clinician to check that the patient can hear and understand what is going on. And I know I don't want to teach you these very basic things because I'm sure anybody who's treated patients will know that there are some who can hear better than others. Some people, some doctors, as Dr. Senad has said, might not have an accent that is easily understood in that particular area. My Welsh accent might not be readily understood in Scotland, for example. I have great difficulty with Glaswegian. So it's very clear that the patient will have the opportunity to understand, we hope, that the doctor can hear and can understand. And there's actually one case about a poor patient who didn't understand anything that a Spanish doctor was saying to her. And she agreed to something that afterwards she said she would never have agreed to. And that didn't help either party.
Vivienne, I'm sorry to interrupt, Vivienne. We're running out of time. I know you have another slide there.
I'm just going to say, yeah, the checklist.
So if we can move on, and this will all come back. You'll have this. Everybody who's listening now will have this information you can keep to you. So if we move on perhaps to the other slide now. And the next one. Thank you. And the next one. Sorry, Vivienne, I'll just move it on because we'll come back to. We're running out of time. So having heard everybody, Senad and Vivienne, have all said about time and needing to capture evidence and the clarity of detail, what we've done at Dictate.IT is try to develop the systems using the artificial intelligence to aid clinicians to do this. So how do we get involved with that? Well, if you want any more information, there's a link on the last slide, or you can go to our website and ask about them. And we've got far more information there as well. So before we move on to questions, one last point, please, from Vivienne. Next slide.
Yes, I apologise for getting carried away about my favourite topic of consent, but I would like to just explain that, and I'm sure you'll all know, the COVID-19 UK public inquiry has now been opened, and among those who will be called to give evidence to that inquiry are doctors, hospital doctors, perhaps GPs who've been treating patients in care homes, and so on. And evidence is currently being gathered and kept safely, stored safely for that inquiry. So another reason for starting from today, being very careful about how things are documented and keeping that evidence in a safe place is that these public inquiries come on from time to time. We just had the infected blood inquiry, people being asked to remember many, many years after the event what had happened and not having the evidence. If you have made good evidence by taking good notes, it's far less likely that you will be called to appear before an inquiry. So that's all I need to say.
Thank you, Vivienne. Thank you very much. Obviously, now we've heard everything we have there. More information on Dictate.IT and how it might be able to help you. We have a free trial so that you can trial it for yourself, no obligation in any format there. But now open to questions from our speakers. Sorry, for our speakers. Any questions?
As we've been talking, Jan, this one's for you. This is, what GP systems is the Dictate.IT solution integrated with?
EMIS and TPP System 1, and there are other ones within the secondary care, but in primary care it's EMIS and System 1.
So while we're just waiting for any questions to come through, I do have a question for Senad. Senad, you said that this saves you time, the solution. Can you estimate how much time it saves you, a week or a day?
Yeah, well, that's a very good question, actually, because it depends on the day. So some days where if I would be having more complex consultations, it would save me more time. So it really varies day in, day out. But let's say that I would typically save hours every week, right? On one day will be more than on the other because I was able to dictate rather than had to write. And this time is invaluable because there is so much to do nowadays, post-pandemic. There are all sorts of things which we have to do, that every single minute, not an hour, is gold worth. And hence, you know, it's a huge time saving and a relatively large one. It's difficult. I haven't really quantified precisely how much it is, but I know it's hours, right? Hours and hours every week.
That's great. Thank you very much. Jan, we've had another question come through for you. So could you just let us know what training's involved with the Dictate.IT solution, please?
Yeah, sure. There's very little needed, actually. What we've tried to do is to keep this very simple. In the past, when these new systems have come out, they can be a bit overcomplicated. And I know a lot of people I talk to now in different practices have said how much that can impact on the practice. So we have kept this deliberately simple. It's therefore simple to install, takes about 5 minutes per user. It is an app after all, so that's for both apps. And it also takes about 15 minutes to train. Once you have that training, you can just try it out. It's so simple, and we can do a demo. I can do a demo for anyone via Teams if needed. But it's very simple, and we have an operations team who work do this. They manage it with the practice, and they work with the lead at the practice to help them to manage this, to put to get the installations for the GPs and the other clinicians, so that they know exactly what time that their system they can do that. We don't have to wait or try to connect with them. The lead at the practice, quite often the practice manager, would do that for us, and then we just work with you to get that installation done and the training at the same time. So it literally takes about 2 weeks to get this set up and running for a trial or for the actual license. And then once that happens, you move to license. Our licenses are the same again, very simple with the pricing. There's no hidden costs at all within it. It's just the license itself. No update fees, no annual fees, no hardware fees. You use the hardware you already have, your mobile phone, microphone, headset, or the web cam speakers.
Thanks, Jan. One more question that we've just had come through here, again for yourself, is how do we access the free trial? I don't know if it's possible, but if we can, of course, we potentially can get the contact details of the person who asked this question. But just in generally, for anyone else who might be interested, how does anyone access that trial?
Sure. On the next slide on here, there is details of where you can request a trial. Otherwise, via our website, there you see me, Jan Donnelly at Dictate.IT. You can come directly through to me, or you can go via our website, which will also come to me, but also the rest of the team, and then simply get back to you at a time that suits you. All I need to start a trial is the email addresses of the people who want to be involved in the trial, what their role is within the practice. We don't charge for secretaries, so as many secretaries or administrators as you like, we don't charge for those. We have a part-time price for anybody who is only 6 sessions or less a week on average. We only charge half price for the service, which works out about £15 a month for both services, Swift and Live. So you have everything there. And then we set up the trial. That's it. If you're EMIS, I need the EMIS number so that we can use the integration broker to join with them. Other than that, that's all I need. So you send that to me at that address. If you didn't catch all of that information, just send me an email and I'll send you back what we need.
That's wonderful. Thank you, Jan. We don't have any more questions that have come through.
Well, thank you very much, everyone. I hope it's been informative. Please do get in touch with me if you need any more information at all. And it would be really good to hear what you think. Thank you.
Thank you very much, guys. Thanks for that presentation. That was great. But like Jan said, if you have any questions or you want to get in touch, her contact details are on the screen. This session has been recorded and it will be on the HTN website along with the write-up next week. So you can access this recording and from all of our other sessions today on www.htn.co.uk. Thank you for your presentation again, and thank you for everyone that's joined us.
Thank you, Emma.
Thank you for the invitation. Thank you.
Thank you.
Anyways, thanks. Bye.